at least 2 sessions or 3 sessions were devoted to transplant in myelofibrosis at this meeting, which is quite amazing because myelofibrosis is not a primary indication to transplant. I mean, so many acute leukemias undergo transplant. But as many of you know, ruxolitinib demonstrated to improve overall survival also in the real life of these patients. So the question now is which patient to transplant, and especially when to transplant these patients. So EBMT guidelines have been recently updated in a joint venture with EHA, but something new is still happening because through an extensive analysis of EBMT registry data is ongoing through artificial intelligence methodology, which will help us also tackling, the right time to undergo to submit patients to transplant, because the highest risk patients, especially based on their molecular profile, high risk molecular profile, and especially patients with a TP53 mutation or multiple hit, adverse mutations are candidate to transplant anyway. And we can bridge patient to transplant by single or double JAK inhibitors. Splenomegaly before transplant is still an issue, but we can manage it, even with the surgery when it is needed. But still, the timing is an issue because patients are not so young. So sometimes you need to decide whether it is the time to undergo transplant because the patient is getting older. Some other times you fear blastic transformation of the disease, which may happen very quickly, and you cannot manage it anymore. And also, we still need to improve, the selection of a donor and of a conditioning regimen in these patients, because not so extensive research have been devoted to MF patients as compared with EML or other settings. So still a lot is being to be studied, such as even ruxolitinib maintenance post-transplant and so many issues.